Welcome to Roadmap to Residency. Hello everyone, I'm Avi. Welcome to our Club 250 Matchmaker sessions. We will be running through a few questions with you guys to help you on a journey to a 250. We are currently in our musculoskeletal system module. So which of the following is the most likely diagnosis? A 25-year-old female presents to the clinic with a history of easy bruising, joint hypermobility, and recurrent joint dislocations. She reports that her skin is unusually stretchy and scars easily. Physical examination reveals hyperextensible joints and skin that is velvety and hyperplastic. Genetic testing confirms a mutation in the COL5A1 gene, which is the most likely diagnosis in this patient. Marfan syndrome, osteogenesis imperfecta, Ehlers-Danlos syndrome, Stickler syndrome, or Loeys-Dietz syndrome. So Ehlers-Danlos syndrome is a heterogeneous group of connective tissue disorders characterized by the joint hypermobility, skin hyperelasticity, and a tendency to bruise easily. The patient's clinical presentation, including easy bruising, joint hypermobility, and recurrent joint dislocations, is consistent with the diagnosis of Ehlers-Danlos syndrome. EDS is classified into several subtypes, and the vascular subtype is associated with arterial and organ rupture. The most common form is the hypermobility type, formerly called as the EDS type 3, is characterized by the joint hypermobility and skin involvement without significant vascular complications. Other subtypes of EDS include classical types 1 and 2, vascular type 4, and the kyphoscoliotic type, arthrochalasia type, dermatosparaxis type, and others. The genetic mutations in the presented case, a mutation in the COL5A1 gene is associated with the hypermobility subtype of EDS. Now, this gene encodes for one of the alpha chains of the type 5 collagen, a fibrillar collagen found in the connective tissues. The defective collagen structure leads to the characteristic features seen in Ehlers-Danlos syndrome. Now let's talk about some of the collagen types that we had to discuss about the different connective tissue disorders. So first one is the type 1 collagen. So these are the thick rope-like bundles of collagen and are the strongest tensile form of collagen. And they make up the majority of collagen in the body, that is approximately 90%, and found in locations where high tensile strength is needed, like bone, fascia, tendons, teeth, cornea, skin. The type 3 of early wound repair is converted to type 1 in late wound repair. It is defective in case of osteogenesis imperfecta, type 1, or which is also called as the brittle bone disease. It is autosomal dominant in most cases. The presentation is multiple fractures with minimal force. First fractures may occur during delivery in severe form caused by collagen mutation. Fractures will be milder and occur later in the childhood with collagen deletion. There is blue sclera, as we are discussing about the osteogenesis imperfecta here. So the blue sclera due to the translucency of the connective tissue over the choroid due to the lack of collagen. There may be deafness in 50% of the cases. There may be some dental abnormalities which may be confused with child abuse, and it is defective in various forms of Ehlers-Danlos syndrome leading to faulty collagen synthesis. The type 2 is a spongy collagen to absorb shock, and it is found in tissues where there are compression forces. For example, cartilage, vitreous body of the eye, the nucleus pulposus of the vertebral disc. The type 3 are the web-like fibers where forces pull from many directions, also called as reticulin. It is found in tissues where strength is needed, but not compression or tensile strength, like skin, blood vessels, uterus, fetal tissue, and granulation tissue. So the type 3 of early wound repair is converted to type 1 in late wound repair. And it is defective in Ehlers-Danlos type 4. The faulty collagen synthesis is associated with joint dislocation, aneurysms, and organ rupture. The type 4 collagen is generally present in the basement membrane, especially kidneys, ears, eyes, and skin. It organizes or solidifies the cellular structure, and it is defective in case of Alport syndrome, which affects the tissues where type 4 is most prominent. Like in kidney, it can cause progressive hereditary nephritis. In ears, it can cause deafness, and in eyes, it can cause ocular disturbances. The majority of cases are X-linked dominant, and one of the causes of epidermolysis bullosa is the Alport syndrome or the type 4 collagen defect. The weak union of dermis and epidermis of the skin can easily form the blisters. The Goodpasture syndrome involves an autoantibody against the collagen type 4 in pulmonary and glomerular capillaries present with hemoptysis and glomerular disease. Now, talking about the Ehlers-Danlos syndrome, it is the defective collagen synthesis where the group of rare connective tissue disorders and there is tissue fragility. It is a single gene disorder, maybe autosomal dominant or recessive. The causes may be the gene mutation, which can cause defective fibrous proteins and enzymes, and it can lead to the increased elasticity of the tissues, structures, and decreased strength of the tissues. The minor injuries can cause gapping defects, and there is repair which is difficult due to the low tensile strength among the collagens. The risk factor is generally due to the family history. The complications are colon, a large artery, corneal rupture can occur, retinal detachment can be there, diaphragmatic hernias, premature arthritis, pregnancy complications like cervical insufficiency, and premature rupture of membranes. So due to the cervical insufficiency, sometimes the patient may just complain with recurrent abortions in case of Ehlers-Danlos syndrome. The signs and symptoms in the skin, there may be hyperextensible, fragile, vulnerable to trauma, easy bruising and atrophic scars, ligament laxity causing hypermobile joints and joint dislocation. There can be pes planus, pectus excavatum, or high arch palate in case of bones and joints, and there may be some cardiovascular findings too in case of Ehlers-Danlos syndrome, which may be spontaneous artery dissection, valvular disorders, artery rupture, Raynaud's phenomenon, and impaired platelet aggregation. There can be spontaneous organ rupture, and there may be cerebrovascular rupture in case of Ehlers-Danlos syndrome. The diagnostic approaches are clinical examination, which is where we can see the typical presentation like lens dislocation, hypermobility, and there is something called as the Beaton score, which evaluates the hypermobility, and it has typically the 9 criteria. The Ehlers-Danlos specific genetic panel may be there for confirmation, and skin biopsy is always an investigation of choice. The treatment is according to the type. There may be some pain medication like NSAIDs or for arthralgia and myalgia, and the surgery is also according to the type where we do the joint surgery for severe arthritis. So the other interventions are like education or counseling, the physical therapy or casting to stabilize the joints. Now we have one more question here. So which of the following antibodies is most likely to be found in this patient? A 45-year-old woman suffers from recurrent non-pitting edema of the hands. She often wears warm gloves in indoors because her fingers turn blue when they are cold. She also complains of retroexternal burning and regurgitation, especially when supine. Now, which of the following antibodies is most likely to be found in this patient? Anti-dsDNA, anti-centromere, antihistone, anti-SSA and SSB, antiphospholipid. So there are two main subtypes of systemic sclerosis. The diffuse scleroderma, which is characterized by the diffuse skin and visceral involvement, and CREST syndrome, which is associated with localized skin involvement and a more benign course. CREST is an acronym for the signs and symptoms like calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Anticentromere antibodies are specific for CREST syndrome and found in 40% of the cases. The anti-DNA topoisomerase 1 antibodies are highly specific for systemic sclerosis. The patient in the vignette has CREST syndrome. The Raynaud's phenomenon causes painful episodes of pallor, cyanosis, and erythema of the hands in response to cold or emotional stress. These episodes of vasospasm can last minutes to hours. Esophageal dysmotility is the result of fibrosis and distal esophagus with associated with esophageal hypermobility. It manifests with symptoms of gastroesophageal reflux. The sclerodactyly is thickening of the skin of the hands and feet, and it begins as non-pitting edema of the hands and fingers. Later in the course of the disease, the skin becomes thickened, tight, and shiny. Thinning of the skin atrophy follows after that. Telangiectasia occur in the skin of the face, hands, and upper trunk, and on mucosal surface. Calcinosis refers to subcutaneous calcium deposits, which may be asymptomatic or painful. Now, reviewing the first part of the scleroderma, so it is also called as systemic sclerosis, triad of autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. Commonly, sclerosis of skin manifesting as puffy taut skin without wrinkles, fingertip pitting. Can involve other systems, example renal, scleroderma, renal crisis, treated with AC inhibitors, pulmonary causing interstitial fibrosis, and GI causing decreased peristalsis and LES tone, lower esophageal sphincter tone, causing dysphagia and heartburn. Can cause some of the cardiovascular symptoms too. It occurs 75% in female population, and there are generally two major types: the diffuse scleroderma and there is the limited scleroderma. Diffuse scleroderma is widespread skin involvement, rapid progression, early visceral involvement associated with anti-SCL70 antibody or the DNA topoisomerase 1 antibody and anti-RNA polymerase 3. The limited scleroderma is where there's the limited skin involvement confined to the fingers and face, and also with Crest syndrome causing calcinosis, cutis, anticentromere antibody is positive, Raynaud phenomenon is there. We can see esophageal dysmotility, scleroderma, and telangiectasia. It generally has a more benign clinical course. So the answer here is anticentromere antibody. Thank you for watching.